So let's get rolling. So I chose the cardiac arrest drugs tonight to talk about. So primarily, we're going to talk about epinephrine, amiodarone, and lidocaine. So I got a couple of them sitting here for us, ready to go. So we're going to talk through those. A little bit of that will come into play as well with just the sequencing of drugs, a little bit of our cardiac arrest algorithm. But then really I'm just starting to look at it for just kind of reviewing the medications, getting some of those numbers out there, just keep us going on what we use them for, when we use them, the different types of rhythms, and a little bit of all of it. We'll also touch on some of the other drugs that can come up in cardiac arrest, a little bit of some of the H's and T's stuff from ACLS as well. So epi, amio, and cardiac arrest, and lidocaine for cardiac arrest. So certainly when we're talking cardiac arrest, first line drug for us is always epinephrine. Epinephrine is our first line drug for cardiac arrest, so that's where we're going to start first tonight, is with epi. So before we get into the kind of arrest sequence, it's helpful to go back to mechanism of action, right? The class, what medication it is, why it's actually working, what it does in the body, and then really what's the principal reason that we use it for in terms of cardiac arrest. Okay. So epinephrine, remember its class is sympathomimetic. Sympathomimetic. So it's mimicking the sympathetic nervous system, right? And that sympathetic nervous system is our fight or flight response, or increasingly fight, flight, and freeze response. Fight, flight, and freeze. Right? So it's all that kind of high stress, let's amp everything up, right? So that's what epi does. It's the naturally occurring chemical in the body that does it, right? It's adrenaline. And that's the other name for epinephrine, is adrenaline. So it's what our body naturally produces by the adrenal glands, but we can come along and supplement it if we're trying to get that extra boost to try to get some stuff going. Okay? So in the sympathetic nervous system response, in this sympathomimetic class, is what we call the adrenergic receptors. Adrenergic receptors. Remember, the adrenergic is just another name for the sympathetic nervous system. So sometimes, not nearly as often, but sometimes it'll reference it as the adrenergic nervous system. Again, just an interchangeable word for us. So the adrenergic receptors, right, there's kind of three primary categories of them that we talk about. Right, one of them is our alpha receptors, right? That is our alpha. And then we also have our beta receptors. Right? And we split beta and we talk about them as beta 1 and beta 2 for them. And again, I probably told some of you guys before, but alpha is kind of the simplified level that we really started at and really kind of leave it at for the most part, because it addresses everything well enough for the reasons why we're talking about it. But the reality is there's also alpha 1 and alpha 2 receptors. Just like we have beta receptors, we have a beta 1 receptor and we have a beta 2 receptor. So there's alpha 1 and there's alpha 2, some slight variance in what exactly it kind of causes inside the body. You'd have to kind of get back into some of the pharmacology books to drill down to that next level for it. And there was actually one book that I saw one time said there's a alpha 3 receptors, right? Alpha 3 receptors. And the book actually said they've identified them, but they don't know what they're for. And so it's like, all right, well, we have enough other stuff that we need to kind of study and talk about and learn that it doesn't really benefit us to open it up to a level where they don't even know what it's for. Right? So we just simplify it and we talk about it with alpha. Right? So alpha receptor stimulation, right, will cause vasoconstriction. That's what alpha stimulation does. Causes those blood vessels to vasoconstrict back down. Right? Other ways that they can phrase vasoconstriction would be an increased systemic vascular resistance. increased systemic vascular resistance, or increased SVR, systemic vascular resistance. Another way that they could phrase it would be increased peripheral vascular resistance, or increased PVR. Increased systemic vascular resistance, probably a little bit more commonly talked about than increased peripheral vascular resistance, but they all can kind of really be used interchangeably. But all it means is vasoconstriction, right? If we clamp down those pipes, right, if we vasoconstrict everything down, then the blood pressure will come up, right, which is a beneficial thing for a whole lot of the reasons why we would use epinephrine, and certainly in the context of cardiac arrest, which we'll get into, is that vasoconstriction is a very beneficial thing. All right, so we always have to think about stuff in kind of medical terminology and textbooks and national registry, where you always got to think about it and say, how else can this be phrased? And so if they say, if we've been talking about vasoconstriction this entire time, always just keep asking yourself that question in the back of your mind, says, how else can this be phrased? Right? How else can this be phrased? Right? So vasoconstriction, increased systemic vascular resistance, increased peripheral vascular resistance. On the beta 1 side, remember beta 1, we have one heart. And on beta 2, we have 2 lungs. So it kind of gives us a little bit of an idea of where we're going to see these particular effects. All right, so beta 1 effects is all of our cardiac effects. Right? Beta 1, we got one heart. So they're all our cardiac effects. So things that we can do to the heart in the context of that fight, flight, or freeze response of let's amp everything up. It's that high stress phase, so let's amp everything up. When one of the things we can do is increase our heart rate. And we can just speed everything up and make that heart actually pump a bit faster. So increased heart rate. Another thing we can do is increase what we call the contractility, which is how strong that heart contraction is, that muscular contraction of the heart, right? How hard it actually pumps. Separate concepts. A lot of these all kind of start to work together, but they're separate kind of concepts. So we can increase the heart rate, we can increase the contractility, and then another one that we can do is we can increase, we'll say, the speed of electricity. Speed of electricity. Right? The heart operates off of that electrical conduction system. Right? So if we're ramping everything up in this fight or flight response, we can increase the speed of the electricity actually moving through the heart. And the faster that electricity moves through the heart, the stronger the contraction should be. Right? The faster the electricity moves through, the faster it'll recharge, so it can fire again. Faster to recharge, it can fire again. So then our heart rate starts speeding up as well. All right, so all three of these all start to kind of play together, but we can talk about them as 3 distinctly different concepts. Because we could have the heart beating 60 times a minute, right? Once every second, right? And we could have it beating 60 times a minute and weak. Or we can have it beating 60 times a minute and loud, right? And strong, right? So the rate is one thing. The strength of that contraction is another thing. Right? So back to my point a second ago, how else can they phrase this for us? Well, they've given it special names. So increasing the heart rate, we call that the chronotropic effect. Right? Chronotropic. The root of that, chronos, is time. A lot of people will take your watch off, flip it onto the back, and on the back of your watch, it'll say chronometer, which is a device that measures time. Right? So chronos is time. So the chronotropic effect is making the heart fire more times a minute, and increasing that heart rate. The contractility is the inotropic effect. And the inotropic effect. And the last one, the increased speed of electricity, is the dromotropic effect. Root of that one, dromos, is running. So think of speed of that electricity moving through, or electrical conduction velocity. Sometimes you might hear them phrase it that way. All right, so we have the chronotropic, inotropic, and dromotropic effects, which is increasing our heart rate, increasing contractility, and increasing the speed of electricity moving through the heart, right, moving through that electrical conduction system. And so all of those things happen when we stimulate our beta-1 receptors. We said on the beta-2, we have 2 lungs. So it's all our pulmonary effects. So when you stimulate beta-2, it causes bronchodilation. So we vasoconstrict with alpha, and we bronchodilate with beta. And that's what we're getting going on there. Right, so alpha is a broad category, beta-1 and beta-2 are the kind of 3 big things that epi does in terms of stimulating the sympathetic nervous system. Epi also blocks histamine release. That's why we use it for anaphylaxis and a lot of these effects that are beneficial for us for anaphylaxis too. Right, but these are the 3 that we're just going to focus on right now. And redirecting it back to our cardiac arrest, kind of talking discussion today, is thinking about which of these is the reason why, or the most beneficial reason why we give epinephrine for cardiac arrest. So we know if we administer epinephrine, if we administer epi, we get vasoconstriction, we get increased heart rate, contractility, speed of electricity, and bronchodilation. So the main reason we give it in cardiac arrest is for the alpha effect, vasoconstrict. Because remember, everything we're doing when we're treating cardiac arrest initially is we're just trying to keep the important stuff alive. That's kind of step number 1, is we have to keep the brain perfused and the heart and lungs perfusing. Because if we can't achieve that, nothing else is going to matter, right? So we have to make sure that we can keep the brain, heart, and lungs all perfusing so we can continue to get the oxygen in, the carbon dioxide out, keep the brain alive, so hopefully it'll start driving everything again, right? But we have to keep that stuff perfused, which means we have to have a suitable enough blood pressure to be able to keep that blood flow actually moving through. Because we know us pounding on the chest doing chest compressions, we know that that's way less effective at circulating blood flow than if the heart was beating on its own. Right? The heart starts beating on its own, that blood starts moving. Right? We're just kind of left with that external pressure of doing the chest compressions to circulate the blood, which is better than nothing, but we know that that's not going to be enough for most people. Right? They need some other stuff. So we're circulating blood the best we can doing chest compressions, but if we can vasoconstrict everything, which will increase the pressure of that blood moving around, then hopefully that can increase the pressure to the important stuff so that we're actually circulating enough blood with enough pressure to perfuse the brain, to deliver that oxygen that we're administering, and to help remove those waste products from the body. So epi for that vasoconstriction is just going to help us circulate blood with a sufficient enough pressure to keep the important stuff alive. We're not given epi because the heart rate's 0 when we're trying to increase it with beta-1 stimulation. That only works if you have a heartbeat in the first place. So we need to keep everything perfused and alive and healthy and well oxygenated. And then we give the body a chance to hopefully start recovering and get a return of spontaneous circulation. So alpha vasoconstriction is it for epi. And the dose, which has been universally true and constant for quite a while, is 1 milligram of epi of 1 to 10,000 concentration, IVIO, every 3 to 5 minutes. So again, it's a good thing when I teach pharmacology a lot. I encourage you guys, script it, right? Script that dose, however it is that you want to say it, and then say it the same way every single time. So when I learned it in medical school, it was epi, 1 milligram, 1 to 10,000 every 3 to 5 minutes, no max dose. Because we don't have a maximum dose. The maximum dose is when we run out of it in the drug box and we're not to the hospital yet. Right? So script it out a certain way, and then it becomes muscle memory, right? And you really start kind of solidifying that knowledge base where you don't even have to think about it anymore. You just know the epidose without even stopping and hesitating. So 1 milligram, 1 to 10,000 every 3 to 5 minutes, no max dose. Other people will say something along the lines of, with a 10 cc flush behind it. So administer the medication and then push flush of saline to help get that medication on board faster. But IVIO, right, 1 milligram is it. The nice part is if you have enough people and you have somebody that's really just kind of charting, tracking, leading that code, and they're timing everything, then all they got to do, regardless of what else is going on, if we're still working a code, they could just sit there with their watch and say, and it's been 3 minutes since the last epi. And, all right, cool, here's another one. And then they'll record the time, and then 3 minutes later, they'll say, and it's been 3 minutes since the last epi. Right? So it's super helpful when you have the resources and you have somebody there that's just calling out the times. Like, hey, just a reminder, it's been 3 minutes since the last epi. Cool, let's get another one on board. All right, let's keep that going. So that is the dose for cardiac arrest for epi. A bit old school, but still testable, a testable knowledge bit would be ET tube administration. So endotracheal tube administration, which is actually saying we're going to administer this medication straight down the ET tube into the lungs. And then we'll sit there with a BVM and we'll bag that epi fluid deeper into the lungs. Then just like pulmonary edema, where we can come along and we can put that high pressure, like CPAP air or bagging our patient, right? That high pressure air is actually going to force the fluid out of the lungs through the alveolar capillary membrane into the tissue, into the bloodstream. So we can do the same thing with epinephrine, is we can pour epi down the ET tube, bag it down into the lungs, and we're going to force some of that epi across the alveolar capillary membrane into the tissue, into the bloodstream. The ET tube administration largely went a little bit by the wayside as more and more places really started carrying IO access. And it was faster, easier, and way more efficient of a system for delivering medications than down the ET tube, at least. But it's still there, right? You can still utilize epi down the ET tube. Again, just less common. One of the kickers is, depending on which book you read, you need to do 2.5 to 3, some places may say 4 times the normal dose. 2.5 to 3 times the normal dose. So if we were going to give 1 milligram of epi, then the equivalent for putting down the ET tube might be 3 milligrams of epi, right? Or 2.5 to 3 milligrams of epi, right? So it's a lot more because you're going to lose some of it along the way. But that's there, right? But vast, most common is our dose of just 1 milligram of 1 to 10,000 every 3 to 5 minutes, no maximum dose. All right, question on that one. That will be for cardiac arrest, correct? Yep, that's correct. Cool. All right, so that's epinephrine. And again, starting line for cardiac arrest, regardless of what rhythm we're in. As remember, when we talk through in a little bit our cardiac arrest algorithm, the algorithm splits to VFib, impulseless VTAC, and on the other side of it is our asystole PEA. The VFib pulseless VTAC is our shockable side. That's where we'll defibrillate. The asystole PEA side is not shockable. Shockable. Both of them, though, the first drug that we give is epi. All right, so we give epi if it's VFib, VTAC, we give epi if we're in asystole. All right, it doesn't matter, that's the first drug that we're going to give. Now, I have heard of some people kind of putting out the idea where we're actually, you know, some of the conversation that might be out there is a little bit of the idea of, hey, we don't have so much in the way of super definitive kind of research-based evidence regarding how effective epi actually is for patient outcomes. And so some people have kind of started to float the idea of maybe one day, if they prove it, they show that epi's not really actually that effective at it, and we would actually get yanked from our cardiac arrest algorithm. Personally, I think that's probably a little ways off from an even, you know, more common conversation. But it just goes to highlight that all of our systems and everything are constantly changing, and at least in EMS, but certainly medicine at large, is just constant improvement to protocols as more research gets done and better evidence comes out. So, but epi's there. Epi yeah, question?
Yes. How often have you seen a patient who's in asystole or PA actually go into a shockable rhythm after being given epi? Or does it happen at all, or it does not?
It definitely happens. There's another question in the chat box real fast. This is being recorded, so we're good there. Yeah, it can happen, and sometimes it's, sometimes where I've heard it, you know, so is they're looking at it, and on the monitor, right, they see something that they're calling asystole that ends up just being a really fine VFib, right? So it actually starts to improve afterwards. But really on the asystole side, right, is that the kind of typical assumption is they've probably been down a little while, and the effectiveness starts to kind of get less and less. Just the longer it is minute by minute that they're down, the less and less and less likely we are to get return to spontaneous circulation, right? So there's that aspect. Like the statistics aren't great, right? It's still well below half of our cardiac arrest patients in most areas. Well below half of the cardiac arrest patients, they actually get return to spontaneous circulation back. On the PEA side, I'd say it depends a little bit on what caused it, right? So we'll talk about the H's and T's for the causes of cardiac arrest. But if you have like a pediatric patient, a peds cardiac arrest, right, their kind of cardiac arrest progression is whatever kind of hypoxic issue is driving the issue. Their heart rate will slow down first, they'll go bradycardic, and eventually that pressure will be down so low that there'll be that bradycardic sinus rhythm, but they'll go pulseless. And so it ends up being PEA. And it's because that blood pressure is just bottomed out because the heart rate's going so slow. So in that situation, giving epi would really, really help. Would really help with it for getting that pressure back up and hopefully being able to actually feel a pulse again. But a little bit that really is depending on what is the cause of it, right? If we capture somebody in VFib pulseless VTAC, right? On an adult side, more likely. The VFib pulses VTAC, we're at least earlier that there's still stuff happening on the heart. So we have a much better likelihood of, making some headway on it, right? Hopefully getting a pulse back on that side. But once it's been true asystole for a long time, or for any period of time, that means this problem has, progressed and been going on long enough that now the heart has just shut down entirely. And it's why you see some places field termination protocols that are, asystole after 3 rounds of epi, you can call for field termination, right? And that just goes to show, like, if we're not getting something right away, we're probably not going to get something, right? That chance of getting a pulse back dwindles pretty rapidly. All right. Cool.
Thank you.
Yeah, you bet. All right. So, epi. All right, so let's see. We'll do amiodarone next, and we'll kind of put all these. We'll just talk through the 3 of them, and then we'll put them kind of contextually in order with the arrest algorithm. So amiodarone. Amiodarone. So amiodarone is an antiarrhythmic, right? Antiarrhythmic or antidysrhythmic. Antiarrhythmic or antidysrhythmic. Right? Interchangeable terms. Right? Some people more likely to use antidysrhythmics, other people more likely to use antiarrhythmics. Either way, it's going to be just fine. So it's an antiarrhythmic. It really, when you look at the class of antiarrhythmics, there's really like 4+ types of antiarrhythmics. Right? So amiodarone just falls into one of the types of antiarrhythmics. Adenosine is an antiarrhythmic, different category. Lidocaine is also an antiarrhythmic, different category. Right? Calcium channel blockers, beta blockers, antiarrhythmics, just different categories. So all just different types. So amiodarone works quite well in that it blocks a lot of stuff, right? It blocks sodium channels, potassium channels, and calcium channels. And remember, those are those membrane channels in our cells that allow for these electrolytes to move back and forth, right? And us having a heartbeat and having that electricity that's actually moving through the heart is the movement of electrolytes in and out of the cardiac cells. So when those membrane channels open up, right, potassium rushes out of the cells and sodium and calcium rush into the cells. That's when that cell depolarizes and fires, as we get this big inrush of calcium and sodium and outrush of potassium. Right, so all those electrolytes move in and that cell is depolarized. Right? And that's the electricity that begins and starts to move its way through the heart. So if we start blocking these electrolyte channels, we're going to start blocking some of that electricity. So you'll hear him say it'll decrease automaticity. Automaticity. Automaticity is that principle that any cardiac cell in the electrical conduction system can on its own spontaneously generate that electrical impulse, right? Any of those cells can. That's what automaticity is. So in this, when we're starting to look at it and starting to think about, all right, we're blocking the electricity because we're blocking the electrolytes, and then we're decreasing automaticity. So if we were in completely asystole, nothing happening, then it wouldn't make sense to try to block the electricity or to try to decrease automaticity because nothing's happening in asystole. So amiodarone is not going to be used for asystole. It's going to be used for a VFib pulses VTAC, right? Where we're getting all of these cells and the ventricles are all firing. They're all firing too much, we have too much automaticity. Too many of those cells want to start kicking out their own electrical impulses. So we need to block or decrease that automaticity. We need to block that electricity so that hopefully a more normal electrical pattern presents itself. Right? But right now we've got all of these cells that are all trying to do their own thing. We need to get those to stop so that hopefully, our SA node shines through, which is what we want to have happen, firing at an appropriate rate. So it decreases automaticity, and because of the kind of blocking of those electrolyte channels, and it's the electrolytes that are depolarizing and then repolarizing the heart as the electrolytes are moving back and forth, then it starts to delay repolarization as well. That's part of this blocking of the electrolyte channels. Right? If we start blocking the channels, we're going to block the channels the cells firing, and we're going to slow down and delay their ability to recharge. Right? So if we start to block the electricity and then slow down the recharge, the repolarization, then all of those cells that we're all starting to fire are going to start firing less. And then again, hopefully that SA node picks back up and kind of shines through, firing the electricity that's moving through the heart. Cool. So decreases automaticity, delays repolarization, but it's really that it works by blocking all of these electrolyte channels. So the indication for us for cardiac arrest is it has to be VFib pulses VTAC. We say we're not going to give it for asystole, and we're not going to give it for PEA. PEA. And again, we can even kind of use the terminology for it and say in PEA, right, PEA can look like a completely good, happy, healthy sinus rhythm, and you just feel it, and there's no pulse. Right? You look at the monitor looks fine, no pulse. Right? So if we're just visually on the monitor looking at that, the rhythm looks good. Right? So if we go back to the class and say it's an anti-arrhythmic, so we're treating arrhythmias, and if we look at PEA, in PEA, the rhythm looks just fine. Right? Then it doesn't make sense to treat the rhythm when the rhythm looks fine. It's because in PEA, something else is going on. We got to go kind of digging and playing detective and trying to find out what else might be going on and what can we do about that. Right? And then in asystole, there's nothing happening. So there's no arrhythmia to fix because nothing's happening. And again, when we said it delays repolarization, decreases automaticity, right? None of those things actually make sense when we've just got pure straight flat line on the cardiac monitor. Right? There's no electricity for us to decrease automaticity. There's no electricity for us to delay that repolarization. Right? So we really need the more kind of chaotic electrical arrhythmias of VFib pulses VTAC, where we're getting these cells down in the ventricles that are all firing way too much. And we need to get those cells to stop firing so that the SA node can come back. So remember, one of the principles in electrophysiology is typically the idea of whatever wants to fire the fastest is going to win. Right? So if all of these cells down in the ventricles are all pissed off and firing fast, they're going to win. That's the rhythm. If the SA node that wants to fire at 100 beats a minute, and that's the fastest thing that wants to fire in the heart, it's going to win. Okay? So generally speaking, when everything's going fine, the SA node does want to fire faster naturally than all the rest of the tissue in the heart, which is why we're all walking around in sinus rhythms from the SA node. Okay? It's once we get the kind of disorganized, chaotic rhythms of VFib pulses VTAC that now it's like, all right, we got to get this electricity to stop so that the SA node fires first. So one of the ways we do that is with these antiarrhythmics. Another way that we do it is defibrillation. This defibrillation is just going to mass depolarize everything and then it's going to allow everything to repolarize, and hopefully SA node is what picks back up. But sometimes when everything is just going crazy, you just got to get it all to stop to give the heart a chance to kind of, get its feet back under it, so to speak. All right, just get everything to stop so we can get organized again. And that's the idea of defibrillation, is get everything to stop, mass depolarize everything, which means everything on its own at the same time is going to recharge. And maybe it just goes right back to what it was doing, but maybe that SA node picks back up. And that's what we want to have happen. So a lot of our amiodarones come packaged in little vials. Maybe they've got some pre-filled, syringes like epinephrine, right? But more so, at least around here, seeing little vials of them. Right? For cardiac arrest, the initial dose is 300 milligrams. 300 milligrams IVIO. And about 5 minutes later, we can repeat it with 150 milligrams IVIO. So 300 initially, 150 on the repeat dose 5 minutes later. Specifically, again, for VFib pulseless VTAC. All right, let's hit the third drug, and then we'll talk our arrest algorithm. All right, lidocaine. Well, lidocaine is another, like I said, antiarrhythmic, different class or a different category of antiarrhythmics than amiodarone. Right? Not a different class. The class is still antiarrhythmic, it's just a different category. So lidocaine is big on the sodium channels, and it's big on the ventricular automaticity. So a similar concept, just different kind of mechanism in the body for how it actually works. So lidocaine will decrease that automaticity as well. It doesn't block all the potassium and calcium channels like amiodarone does, but it will decrease that automaticity. So this is another one that it would only be used for VFib pulseless VTAC, where we have everything firing just way too much. Is we got to get all those extra cells to stop firing, right? So it decreases the automaticity, or sometimes you'll hear them say it'll increase the VFib threshold, right? Which is really just how much irritability can the heart take before it'll kick over into VFib. So by increasing that threshold means we're allowing for more irritability or excitability, just depending on which book you read. More irritability or excitability, right? The bigger that threshold is, the longer it'll go before that heart kicks over into VFib. So increasing the VFib threshold or more electrically decreasing automaticity is really it. That's another one, decreasing ventricular automaticity. So another one, the asystole PEA. Asystole PEA, we're not going to give lidocaine for that, right? It's just on the arrhythmia side, which is VFib, pulseless VTAC. Lidocaine is another one. Usually comes in kind of a pinkish box. Right? Pre-filled syringes that usually have 100 milligrams in there. And our dose for this is 1 to 1.5 milligrams per kilogram. So it's a weight-based medication. 1 to 1.5 milligrams per kilogram. We can do the same thing every 3 to 5 minutes. But this one does have a maximum dose. And the maximum is giving a total of 3 milligrams per kilogram to your patient. So if your initial dose, you gave them 1 milligram per kilogram, 3 to 5 minutes later, Here's another 1 milligram per kilogram. And then 3 to 5 minutes later, we're still in VFib pulses VTAC. Here's another 1 milligram per kilogram. Now we've given a total of 3 milligrams per kilogram. We're done with lidocaine at that point. So you'll either do 2 or 3 rounds if you're staying in sustained VFib pulses VTAC. You'll do 2 or 3 rounds just depending on whether you do 1 milligram per kilogram or whether you do 1.5 milligrams per kilogram. The amiodarone was back one, right? We have the little vials that typically have 150 milligrams in them. So we do 2 of them initially for 300 milligrams, a repeat dose of 150, and then that's it, right? That's the maximum on the treatment during cardiac arrest. Some people do the infusions of them after return of spontaneous circulation, but at least during the cardiac arrest treatment, it's 300 milligrams initially, repeat it with 150. Lidocaine, weight-based, 1 to 1.5 milligrams per kilogram, and then you max out once you've given your patient a total of 3 milligrams per kilogram. All right, so let's take a look at it. We've got cardiac arrest. We said after the kind of BLS side, right, where we confirm pulselessness and we start CPR, right, and then once we start CPR, right, we get the pads on them, right, and we take a look at the monitor, and we're asking ourselves, is this a shockable rhythm? And if we say yes, okay, it's because it's VFib or pulses VTAC. If we say no, it's not shockable, it's because all we've got is asystole or PEA. Now, for national registry and everything, it's straight classic American Heart Association CPR. So for an adult patient, our 30-to-2 ratio, right? 5 cycles of 30-to-2, so 2-minute rounds of CPR. Right? So the classic AHA CPR numbers is what we use here. Right? That's everything National Registry adheres to. Right? And if you go back to like your AHA CPR class and say, okay, it's early recognition of an emergency, early activation of the 911 system, early chest compressions, early defibrillation, right? That's one of their links in the chain of survival is early defibrillation, right? So as soon as we identify, yes, this is a shockable rhythm, right, we should charge up the monitor. I'm clear, you're clear, we're all clear, and then deliver our defibrillation, right? Which a good kind of generic class number is the 200 joules biphasic for an adult. But even the American Heart Association, they'll step back and they'll say defibrillate at 200 joules or monitor manufacturer recommendations. So they allow for the variability for Zoll to say, hey, we've done studies that show with our monitor, defibrillating at 150 works. Cool, do that, right? So monitor manufacturers may tweak these numbers a little bit, but for a number that you can use for class and stuff like that, 200 joules is going to be just fine. So as soon as we defibrillate, we're going to get right back on CPR. We're going to do 2 minutes of CPR. And if we have IV established already, if we don't, we got to get an IV established. If we do have an IV established, then we said the first line drug that we will give is our epinephrine. And then at the end of that 2 minutes, a good thing to script for scenarios and ACLS megacodes and everything is check monitor, check pulse. If we're still in our VFib pulseless VTAC, then somebody can start doing chest compressions while we charge up the monitor again. I'm clear, you're clear, we're all clear, defibrillate, and then get right back on CPR. And we're gonna do another 2-minute cycle of CPR. And in this cycle, we can do an antiarrhythmic. And the antiarrhythmics is we can choose, if you have both, you can choose, I'm gonna do amiodarone at 300 milligrams, or I'm gonna do lidocaine at 1 to 1.5 milligrams per kilogram. Now it really is, it's one, there's some studies that start to show that amiodarone works better, has better patient outcomes. And so a lot of people shift towards amiodarone. And then other studies will come out that shows that lidocaine has a little bit better patient outcomes. And so then people shift towards lidocaine, right? But nobody has won the evidence-based medicine race of which one of these drugs is better, consistently better with patient outcomes. And so for that reason alone, I mean, a lot of agencies, they carry both in the drug box, which means you get to pick which one you're going to use. Unless your medical director obviously has said, hey, here's the one that I want you to use. That other one's in your drug box just as backup. Okay. So amiodarone or lidocaine. I don't know, for us in class, we can pick one. It doesn't matter to me. It's definitely worth the kind of time to take a look at some of the research that's out there and figure out, you know, where is the kind of general consensus. But, you know, and it seems like, you know, different situations for cardiac arrest kind of lend itself to different medications. Okay. But on the kind of classic basic starting point of like the ACLS cardiac arrest algorithm is pick whichever one, pick which one you have, and then use that. Okay. The kicker is if you do have both, if you have lidocaine and amiodarone, and you're allowed by your protocols and stuff, you're allowed to just pick whichever one you want. Once you pick one for that patient, you got to stick with that antiarrhythmic for that patient. So you can't use like amiodarone one round and then go use lidocaine the next round, and then let me do amiodarone again, and then lidocaine again. You pick your antiarrhythmic, and then you stick with that one for that patient.
So what's the favorite then?
I'll tell you, a lot of students, their favorite is amiodarone just because there's no math. They don't have to do a weight-based conversion with 1 to 1.5 milligrams per kilogram like lidocaine. So whether it's a big adult or a little adult, 300 milligrams. And so a lot of people like that just for the 2 a.m. paramedic brain. But yeah, it really is like there's studies that show amiodarone works better, and then you turn around and there's another study that shows lidocaine works better. So it's definitely not a finalized decision at all. If there ever was one, then we would all shift to just using that one drug if they could show that one was definitively better than the other. So since they can't, they keep leaving both of them in there as options. All right, so questions. There's no max dose for epi, but if there's no improvement, you would then go to the antiarrhythmics. So if we're in the VFib pulseless VTAC, we'll start with epi. We'll do a round of epi. The next round of CPR, if we're still on VFib pulseless VTAC, we go right to an antiarrhythmic. And so we almost end up alternating epi, antiarrhythmic, epi, antiarrhythmic. Because we're doing both of those drugs on 3 to 5 minute cycles, right? Epi every 3 to 5 minutes, amio every 3 to 5 minutes, right? So it works out that we can do epi, antiarrhythmic, and then epi, antiarrhythmic. We're just spacing them out. So it's 3 minutes between the epis, 3 minutes between the antiarrhythmics. Yeah. Cool. And so that sequence really continues on the VFib pulseless VTAC side, right? Is doing the, we're going to defibrillate every 2 minutes as long as we keep staying in VFib pulseless VTAC. We'll keep defibrillating every 2 minutes. We're going to continue doing our 2-minute cycles of CPR. We're going to do 1 milligram, 1 to 10,000 epi every 3 to 5 minutes. And then interspaced in between that, we'll start doing an antiarrhythmic, just keeping in mind that we will max out once we give our repeat dose of amiodarone at 150, or once we reach our max of 3 milligrams per kilogram. And then once we're done with the antiarrhythmic, if we're still working that code and there's still in VFib pulses VTAC, and we've used up all the antiarrhythmics that we're going to do, then we're just defibrillating every 2 minutes, doing those 2-minute cycles of CPR, and we can continue doing epi every 3 to 5 minutes as long as we have more epi. Yeah, so good question. He's only worked in California. Would you typically work the patient for 20 minutes, at least in Arizona? It definitely depends. It really does. I mean, it depends even within crews within a department. Because in the whole Phoenix area, we're never more than a handful of minutes away from a hospital. We're almost always very close to a hospital. So some crews get them loaded up, get them to the hospital as quickly as possible. Other crews will stay on scene and work that code for a much longer period of time, try to get some sort of positive direction movement with that patient and then transport them to the hospital. But then you drop down to like Pinal County and go to some of those further out areas where they're acknowledging they're going to have a longer transport time. Then they're much more likely to say, hey, if we do 3 rounds of epi, which is every 3 to 5 minutes, so 9 to 15 minutes of epi, if they're in a systole for 15 minutes, you can call the hospital for field termination. So some places will get much more aggressive on it and say, hey, yeah, 15, 20 minutes to your point. And then say, okay, if we're not getting some sort of movement, if we're staying asystole, let's consider field termination. Versus let's load them up and get them to the hospital because we got to drive. So not a set in stone number around here at all. I've seen both. I've seen the crews that stay on scene for a long time to either get a pulse back or not. And I've seen the crews that they get there, do the first couple things that they need to do in cardiac arrest, and then they're loaded up and they're driving. They're trying to do all the rest of it on the way to the hospital. So I've definitely seen both. All right, on our asystole PEA side, so we said is not shockable. So in this, all we're doing is 2-minute cycles of CPR. And we're doing our 1 milligram of 1 to 10,000 epi every 3 to 5 minutes. That's really it. We're not doing the antiarrhythmics. We're not defibrillating. Right? So we're just doing epi, 1 milligram, 1 to 10,000 every 3 to 5 minutes, interspersed with 2-minute cycles of CPR. And that's really it. That's it on kind of the standard sequence, beyond trying to figure out what else could have been causing this. Right? That's just the basic treatment of asystole PEA, is that part. So very simple on that side of it. 1 drug, 2-minute cycles of CPR, that's it. All right. So what happens, and certainly for the EMTs that then go to paramedic school, and you're used to being the one doing the CPR, sweating, your heart's racing and everything, you're doing all the chest compressions, you're doing all the work. Sometimes it's a hard mental shift for some paramedic students to separate themselves from doing the chest compressions and to step back and think about leading the cardiac arrest. Right, where you can be sitting there and say, okay, we're going to defibrillate. I want you to resume CPR. And this round it's epi. So I want you to give 1 milligram of epi. And then you turn around and you're like, okay, I've got 1 minute and 45 seconds left in this 2-minute cycle of CPR. Now, all of a sudden you realize, I got a lot of time. right? You're looking at that person, making sure they're doing good quality chest compressions. You're looking at that person, making sure they're ventilating appropriately. And then you're starting to think through, all right, well, what's the next drug that I'm going to do if I stay in this rhythm? All right, next up is amiodarone. So let's go ahead and get the amiodarone ready. Right? And you look at your watch, you're like, all right, I still have a minute left of this 2-minute cycle of CPR. Right? So it really opens up a lot more time to kind of step back and think about, you know, what's going on with this patient? Why did they go into cardiac arrest? Is anybody around that knows the patient or saw what happened? Right? So we start going looking for causes, because something caused them to go into cardiac arrest. So we got to figure out if we can find the cause. Did they have a heart attack, an MI, and that's why they went into cardiac arrest? Is it because of a drug overdose, and that's why they went into cardiac arrest? Did they go into cardiac arrest because of hypoglycemia? Did they go into cardiac arrest because of sepsis and hypovolemic shock? Okay. So we got to consider that. And that's where when you step back into paramedic mode, separate yourself from the one doing the chest compressions and all that, you start to realize, I've got time. I've got time to think about stuff. And so I keep saying it, right? We've got, they call the H's and T's. Okay? Is things to consider and things to evaluate for why did my patient potentially go into cardiac arrest? Why did they go into cardiac arrest? And so it's a good little checklist for us. And that's all it is, it's a checklist. And it's really the same checklist that we can use for an altered mental status patient. They're not completely in cardiac arrest, but they're altered. Something caused that. Right? So they kind of framed it, you know, for H's and T's. There's another one, which is patch for MD, right, where there's 4 H's and then the other letters. It's all the same stuff as the H's and T's. They just phrase it differently. And so it's just a different abbreviation or a different acronym. So some of them we can look at and say, okay, one of the H's can be hypovolemia. And so all we got to do is turn around, look at our patient. Did we start an IV? Are we giving fluids? Okay, we're dealing with that one if that caused it. Hypoxia could cause cardiac arrest. Well, we're bagging our patient with high flow oxygen, so we're dealing with that one. Sometimes they get creative to make it fit in the acronym. They'll say hydrogen ions, which is us considering, is there an acid-base problem going on inside the body? If they are for cardiac arrest, most of the time it pushes them towards a respiratory acidosis. So by ventilating them well with good quality oxygen and really allowing for that air movement in and out, you start to deal with the respiratory acidosis, at least a little bit that way. It's also where some places used to have sodium bicarb as a more standard treatment drug to deal with the expected acidosis of cardiac arrest. They really kind of pulled back from just having that as a set in stone spot in the cardiac arrest treatment algorithm. And like on our drug profiles that we use, it says it's used for cardiac arrest after all other interventions are performed. Right, so like after you've done everything else you're going to do for cardiac arrest, then maybe you could try bicarb. Right, but it really is us getting into practicing medicine, because we're not drawing the blood to test to see just how acidic they are, and then to use that objective data point to then guide how much bicarb should we actually use. Right, so you really need, I mean, it's better to operate that way. Get some lab work to show that they're acidic, and then say, okay, yep, they are acidic, so it's indicated for me to do bicarb. So a lot of places have kind of backed off of bicarb. Some places have just removed it from the drug box entirely. So hypovolemia, hypoxia, hydrogen ions, hyperthermia. Is it an environmental exposure? Hyperkalemia or really any electrolytes, but potassium is a big one to push people to cardiac arrest. Think about like a dialysis patient that's missed their dialysis appointment multiple times, right? It usually results in a buildup of potassium amongst a bunch of other stuff too, but a buildup of potassium will push somebody from a sinus rhythm into VTAC and VFib cardiac arrest. Another one could be hyperglycemia. And so if you remember this list, right, then as you're working a cardiac arrest, as your partner is doing CPR and everybody else is doing everything, and you're stepping back just evaluating everything, you have this little just kind of framework in your head, this little checklist, and say, okay, could be fluid. Well, we're running fluid, so that's not it. It could be blood sugar. Did we get a sugar off that IV that we started? Let's check that blood sugar because maybe we need to give them dextrose. Or hey, did anybody see them? Did they look like they clutched their chest before they collapsed? Did anybody see what happened? Right. That's one of the T's. Right. Is a thrombosis. Right. And they'll say thrombosis coronary, which is an MI, or a thrombosis pulmonary, which would be a pulmonary embolism, right? A PE. Right. So again, those would really need some history, right? If we get there and they're in cardiac arrest already, we won't really know this unless there's something really cluing us in. Now, we need a bystander to say, yeah, they were clutching at their chest and they collapsed to the ground and we called 911. We could say, okay, decent chance that that might have been an MI that they had that contributed to it. Another one is toxins. Toxins. So you can think drug overdose. So is there anything that's making you suspicious of maybe a narcotic overdose? We could try some Narcan during the code as well. So thrombosis, toxins, temperature got picked up a little bit there. Tension, pneumothorax. Another possible reason, right? That's a life threat. It's a reason why somebody could go into cardiac arrest. It'd be easy as our partner is bagging the patient during the cardiac arrest, we're listening to breath sounds. We're looking for equal rise and fall of the chest. So do we see one-sided rise and fall of the chest? Well, let's go listen to those breath sounds, see if they're absent on that side and we need a needle decompress. And another one is tamponade cardiac. Again, they had to manipulate it to make it fit in our H's and T's. So cardiac tamponade. Another one that during the code, we don't really have a mechanism to evaluate that. You know, we have some frameworks like Beck's triad, which is narrowing pulse pressure, muffled heart tones, and JVD that can clue us into a patient having cardiac tamponade. None of those three things will be there when they're in cardiac arrest. Their heart's not beating, so we won't have muffled heart tones. Their heart's not beating, so we don't have a blood pressure to look at a narrowing pulse pressure. And their heart's not beating and circulating blood well enough to see that it's actually backing up in JVD, so we can't really see that one. All right, so that's another one that doesn't really lend itself to the kind of diagnostic ability that we have in the pre-hospital setting. But these are some of the things that we're thinking about. And again, if you look at them, every single one of these things on this list could cause somebody to be altered. So we should check their fluid. We should check oxygen. We should check their temperature, electrolytes, sugar, 12 lead for their heart, toxins, tension pneumo, cardiac tamponade. All of those things could make somebody altered. And so it's really the same checklist of us trying to just figure out what the heck's going on with my patient. And if I can identify that, then maybe there's something that I can do about it. I can give them fluid. I can give them oxygen. I can give them sugar. I can give them Narcan. I can do aspirin nitromorphine if they were alive with an MI still. So it's really just a little bit of a checklist that we have to help us identify what they call reversible causes. if we identify that one of these things is happening, we can fix these things. Or some of them, like cardiac tamponade, the hospital can fix. We can't really fix them. So H's and T's is a good thing. That's what we're doing during our downtime. Right, during that downtime during the code, which is during this 2 minutes of CPR, right? And all you got to do once we're done here, I'm not going to waste everybody's time to do it, but once we're done here, just take a look at your watch and set a timer for 2 minutes and just sit there and feel how long 2 minutes actually is. Too often people start spinning and they start going too fast. Right, slow down. This round, all right, let's defibrillate the patient, resume CPR, 1 milligram of epi, 1 to 10,000. A minute and 50 seconds to go. Somebody get a sugar off of that? Hey, let's consider some Narcan as well. Let's prep our intubation equipment too. Anybody else, anybody know the patient? They got a past medical history, something that we can find out about? Okay. Still got another minute to go, right? It's a long time, right? It's a long time. So in that time, we have the ability to evaluate, hey, I don't need to be there doing the chest compressions. I need to be thinking through the other things that could have happened that contributed to this. Cool. So that's really what I got. A good solid hour of those 3 drugs, just how they fit into cardiac arrest. So I appreciate you guys hanging in here and watching it. I hope it was helpful for you. If you have questions on this, I'm going to stick around for a bit, or if you have questions on anything, I'll be more than happy to answer that. If this is all that you came for and you just want to watch that and that's all you wanted to see, then cool. I appreciate you hanging out. And hopefully, like I said, that this was helpful. So thank you again. But like I said, I'll hang out here for a bit if you got questions on cardiac arrest or pharmacology, or really kind of opening it up to anything. I'll be happy to answer for a little while.